Good afternoon. I'm Andrea Restifo, and today we are joined by South Shore University Hospital, our colleague Joseph DeLugesh, who set up the educational series, Dr. Derek Ramo, Miss Marianne Martino, Miss Donna Moravec. We have prepared a video that I think you'll really enjoy on the electronic medical record and the use of data. And I know we're going to be able to play that for you now. Good afternoon, everybody. I'm Andrea Restifo, Associate Executive Director at North Shore University Hospital. I'm an RN who leads up the quality and safety program here. Dr. Joseph DeLugesh and I are very excited that the American College of Medical Quality has this continued series on quality topics. Today's topic, the electronic medical record, artificial intelligence, machine learning as a database for understanding new processes, will help you see how we think big and we start small. We're lucky today to have our colleagues from South Shore University Hospital here to show us how they've gained insights to ways to get data through these methods and now can analyze it and better understand complex issues. You will see how they extracted intelligence from their data so they can improve outcomes and processes at their hospital. I'll turn it over to Dr. Joseph DeLugesh for some opening remarks.
Good afternoon to all. Today's topic will be very exciting. We are focusing on analytics and what makes analytics work in a very complex organization, an organization that went through a transition from a community hospital to a major teaching hospital. In their latest approach to data, that we'll be more than happy to share with all of you how they use it on a daily basis to improve processes. The latest project they are focusing is on artificial intelligence. And I had an opportunity to look in the media about artificial intelligence. And what you see in the first slide is really an outcome of a review on artificial intelligence, what it means, and the limitation of this particular program. Ezra Klein is a well-known theoretician and economist in healthcare who writes a lot in the opinion section of the New York Times. And I read his article, and I fell in love with this quote, and saying that AI is good as long as we know what we are doing. And in fact, there is a very big issue now in education, in schools. What does it mean and how it affects the way we study? In healthcare, there is a major limitation because they feel that answering a medical question or summarizing doctor-patient interaction relationship may create major problems. And the problems will be in terms of oversight. How do we control what it says and what are the limitations to what this type of program can develop and say in the future? And as a client feels that this will have an impact, an economic impact in healthcare in terms of monitoring artificial intelligence. And today also we are discussing in the media what are the limitations of artificial intelligence. In fact, now there is a discussion how it can affect civilization and what type of quality control they need to develop in order to control this type of growth. With that introduction, I'd like to introduce the team from Southside University Hospital. We have the CEO, Donna. Would you like to introduce yourself?
Sure. I am Donna Moravec. I'm a nurse practitioner, and I have an MBA. I've been in our health system since 1981 when there was no such thing as IT. And I have been at South Shore University Hospital for 11 years and realized one of the most, as we put this together, one of the most common threads through everything we do every day is quality and IT.
Dana is very modest. I worked with Dana in North Shore University Hospital. She was in charge of the cardiac program, and we used enormous databases, not AI, but we did use enormous databases to understand the patient population.
Absolutely.
With us also is Dr. Ramo. Would you like to introduce yourself?
Thank you, Joseph. So I'm Derek Ramo. I've been an emergency medicine physician for just about 20 years. Currently work with Northwell Health for just over 10 years. My current role is the Associate Medical Director as well as the Chief Medical Informatics Officer here for South Shore University Hospital. As the Associate Medical Director, a lot of my job involves programs, program growth, as well as care model, and really just everything that the providers are doing here in the hospital. I help to try to make it easier. As the Chief Medical Informatics Officer, my job focuses more on the interface of IT and the user, in particular the clinical user. My specialty, more than data analytics, is actually workflows and workflow improvements. That's really where I spend most of my days, but it's all under the board certification that I have in clinical informatics as well.
Thank you. And Marianne, would you like to introduce yourself?
Yes, thank you. Marianne Martino. I am a nurse, and I oversee here the quality and safety programs as the Associate Executive Director at South Shore University Hospital. I've been with the health system 20 years. I'm a nurse 30 years. I've been in quality for 15 years, and I think that's where I start thinking about the IT, because when I came into the quality world, everything was by paper. We had no electronic medical record. If we were looking for data, it was all hand. We had to look through all the charts by hand. So the use of all the databases and being able to connect to the electronic medical record to find outcome measures and look at processes is tremendous. And I love the growth that I've been a part of, in my tenure.
I noticed that you have an MBA, so this helped you with data?
Sure. Going through the MBA process and learning, it's not just about, having a nursing background, but then having the business side and being able to do the analytics and understand data and process and outcomes. Sure.
Great. Can we move to the next slide? And Dana, if you don't mind, I have one question, is that how technology, what kind of a role technology played in the changes from a community hospital to a thriving university?
Absolutely. Part of having been here 11 years and looking at the data when I first walked in this building, it was a lot of paper. It was a lot of data that was old. Looking at where we've progressed and where we are now is looking at data on a daily basis. And you'll see that later on in this PowerPoint. Some of this, the changes that have happened in this institution as we look at this, is our growth with all of our employees and our patients. But our patients are very diverse. They come from really different backgrounds, whether it be south of Montauk or north of Montauk. What we see is through an EMR, we do a lot of screenings for a lot of our patients. One in particular is our food insecurity screening. Our physicians and our nurses do an immediate question that flags a social work consult. And that social work does a more in-depth screening where we have a food bank here at South Shore University Hospital. It is really for patients who need immediate food. You look at Maslow's theory of hierarchy. You don't have food, you don't have warmth, you don't have comfort, you are not going to get anywhere else. So it is pivotal to have this kind of a program. We have a trauma program. We look at ESPERT. We do a lot of patients coming in, see if they have been drinking or if there's anything else we need to focus on. So it's not just physical, it can also be psychological. All of this has translated into a hospital transitioning from Southside Hospital to South Shore University. And our EMR was put in this building about 9 years ago, 10 years ago. And it has completely given us the transition to everything and given us the opportunity to connect every single aspect of this institution.
So As a result, did you had to send your employees to take courses in IT or?
We actually had, working with a large system like Northwell, we actually had people on site who were here. In fact, that is how Dr. Ramo came to this institution as our associate medical director. We called it the Big Bang, where everything transitioned over to IT. Having been in the cardiac world, like you mentioned, I had immense knowledge of echo, stress, and the IT in a world that was pretty much unilateral. But what I saw is as you integrate that into a larger entity like an EMR, you have everything at your fingertips, which is pivotal for patient care and quality outcomes.
So your decision processes change is much more rapid now because you have information.
At your fingertips. It's available through our intranet. It's available. In the past, you'd have to wait to get your data back to you as it was collated and reviewed. Now it's instant and everything. We even have a huge board right at our fingertips in the executive suite where I can tell you how many minutes an OR case took, what's going in there. We have helicopters landing. That's all part of movement and transition.
In the next slide, we are talking about the specifics of the scope of care that you have in your institution. And two things that intrigues my imagination. One is the robotic, which is completely data-based. Of course, you have others, which is very exciting, but this is one. And then the other one is, as you recall, we implemented the Apache system many years ago in offshore in the ICUs because it simply provided information that today AI can benefit, because the Apache was really to help us with the processes, not to change or predict the decision making. Am I right? It's only the process. And the same thing with robotic surgery. So would you like to make a comment on that?
Sure. Being an ICU nurse, the Apache system at Manhasset was a tremendous addition. It kind of gave you a quantitative number of patient care, how we would care for that patient. At South Shore, as we add things, having the luxury of seeing something like an Apache really dictate where we need to go and what we need to do and what kind of services we need in the building. As far as robotics, what is amazing to me is we started the robotic program at Manhasset many, many years ago. And I was intrigued that someone in Germany could operate at Manhasset with a robotic system, but it articulates now, it is intuitive, and the physician has to be nowhere near the actual sterile field. As we go back there and watch some of the procedures, it is amazing with some of the cancer surgeries. You think about manipulation of a body part that has cancer cells. Having a robot there with minimal incisions and minimal retrieval of an organ or a part of an organ is tremendous. What's important about this scope also is we are the easternmost tertiary anchor of the largest health system in the state of New York. We have helicopters landing. We oversee these smaller community hospital programs. What we implemented in this, to me, has been a game changer. We have patients who go to the smaller hospitals and have a large vessel occlusion as a stroke. We have CAT scan rapid software right now that can rapidly identify the patient's clot, and we can drop a helicopter, transport them here, have the team here, and retrieve that clot. And of our 1,600 transfers, and I believe 500 were level 1 acute, where the patient would have died in the community hospital. So what we've done here is connected all the hospitals. And as you know, a cardiac program, we're the surgical backup for all the cath labs. So in the east end of Long Island, 50 miles away, 45 miles away is Peconic, or 35 miles away. That's a hospital that now is located in an indigent population. There it is at the bifurcation, if you will, of an island. And that allows patients to be delivered care, whether it be there or here. We have the ability to transport those patients. So the connectivity from radiologic perspective, the ability to see robotic surgery here. We're working on a simulation lab here for the Eastern region. That is pivotal for our residency program. So it is something that we need. It is something that we're doing. And I really truly believe we've saved a lot of lives here because of our connectivity back to the smaller hospitals.
Wow. Because the simulation is a topic by
Tremendous.
itself.
Mhm.
And I only want to say that with simulation, you improve the competency.
Absolutely. When we put the open heart program here, we had to have the New York State Department of Health mandated we have 3 distinct people that were the Manhasset program, and that was perfusion, cardiac surgeons, and anesthesia. However, all of the nurses and PAs came from other hospitals. We used the simulation lab where they would interact, take care of a simulation patient, and then play it back. The state of New York was impressed, looking at it for possible remediation. But that simulation lab, we're now working on that, and we're looking at putting some IT or equipment into our new construction, which will be starting next week or the week after, and looking at integrating office charts, EMR, patient's radiologic information, plus teaching to the residency remote over at the CLI Center. So we have a lot of things that will come up in the near future that will continue to integrate everything.
It's really amazing. I'm just thinking that 30 years ago, when we started to look at mortality, we had a problem. It's all done by paper.
Mhm.
The calculation, of course, I use the computer. But in terms of corrective action or competency, we didn't have this technology. So I guess this will play a role in future artificial intelligence. I think this type of work, if we can control this environment. In the next slide, we have, as you all call it, real-time use of data. And I was very impressed because as I went through the corridors of administration, I saw this page illuminated on a computer, and it was very active because it changes constantly. Before I go to Dana, because this is her baby, I mean, this is what she has to make decision. I would love, if it's possible, for either Marianne or Derek to make a comment on that from an analytic point of view.
To your point, when I first started doing this, we used to have an A&M carrying a clipboard around, and she would have beds checked off, or she would have, and she'd ask me, "Do you have any admissions? Where's this patient going?" So there's a lot of communication and a lot of paper. This is all in this report now. It's the to-the-minute decisions that we can make based on this information that is fed to us is exponentially more valuable than that clipboard was.
It's amazing.
Yeah. And just, to get a little bit more into the detail of it, I mean, this report shows us whether or not there is a delay in getting patients out of the emergency room because maybe we need to send a few more transporters and, we're able to make those decisions, or maybe environmental services is backed up a little bit and we can support them somehow. I mean, the key to this is that center box, right, that says that the number of holds that we have in the emergency department are increasing. So what does that mean to us? When we hit certain numbers, we deploy certain teams there, whether it's for comfort for the patients, whether it's the doctors who need to expedite, getting orders in, or, really it comes down to patient experience, right? You don't want the patients, and patients don't want to be sitting in the emergency room. So this is a hot button for us. We watch that all the time. And that's a huge thing for us. I mean, when Donna put this into the hallway, it was an eye opener for all of us who have to look at it every day.
Yeah, because we know that Monday is the scariest day of the week, especially Monday morning at 6 o'clock.
Right.
And when you walk in administration, this is the first thing you do. Right? You look at
Stop
this.
there and stare.
It's there. This helps you to make decision.
As we talked about the transition here, we watch us outgrow the hospital again and again and again. We've tripled our revenue in 11 years. When I look at this, it makes you realize how can we, and we're constantly stopping and talking about process improvement, utilizing this data, right? So you look at So if we have patients with actual discharge information, the question is, why is it taking them so long to be discharged? Or is there a rate limiting step? Why are we ordering some tests? And that's where Derek comes in, and really we deep dive into certain things. And sometimes it's, why are we waiting for a lab on the day of discharge? Does that make sense? And being a clinician myself, I actually pride myself in the fact that I was the discharge queen. We'll send a lab at home and do it on the outside. So a lot of this precipitates, as Marianne said, and Dr. Ramos constantly standing in his doorway. What can we do better here? What is the story? It's, assigned to occupy. I mean, there's a lot of stuff. And as you change the acuity of that patient and the mix and the turnover time in the OR, because now we no longer have those hour cases, we now have 4 or 5 hour cases. What does that do to the need for transport so it's a constant reassessment of what the needs are, especially with staffing in the ER. So it's an interesting snapshot of where we are.
So this is really great. Also, the audience should think it's a very simple table. It's very complicated because it's based on multiple databases.
And yes.
And we need to work on the variables to be the same variables so it can be entered and measured. So I wanted to remind the audience, it's not that simple, it's a picture, it's not a picture.
And Joseph, by the way, a lot of this boils down to CMS stars. That's what Dr. Ramo and Marianne are constantly working on. And this is something that can make or break. And think about patient experience. When there's those 45 holds in the emergency room, patient experience is a huge indicator for CMS stars and for leapfrog and everything that we actually report up to. So we would deploy someone down there to talk to the patients and families and say what's going on.
Great. So really, it warns you if there is an issue, you know immediately. This is really great.
Yeah, and it calls, I'm sorry, but it calls us together as a team. Like we huddle. We'll stop and say, time out. What's happening here? The executive team, and then down to the directors, and then down into the staff to find out what's going on. Where is it? So we're constantly asking what's going on. Donna made a joke about Dr. Ramos standing in his doorway, but that's like a common. His doorway is right next to this screen, so it happens a lot where we're having conversation. What's happening? Why is this happening? And it's a great way for us to stop, huddle, and think about what comes next.
We get a mobile version of this sent to us before we get in on Monday mornings.
Yes.
So we'll already know that all the numbers are in the red, and we'll have planned out day based on that.
When I say it's complicated, it's not only the databases are complicated, but you had to transform your employees, the nurses and the physician, to be able to control the electronic medical records. So this type of data can be delivered.
With all the acute programs we have, cardiac, trauma, neuro, the question is, should a Monday, as you say, be a day for elective surgery? So as we add more ORs, we look at rearranging the OR schedule so that the acuity of the patient with the real high acuity doesn't have to be bumping a patient who's elective.
And to your point, and you heard this a lot, data garbage in is data garbage out. We had to make sure that the definitions of exactly what people are entering were standardized across the hospital. Room to request to assign to occupy, request a room, and make sure the workflow is not only supported, that information being put in the correct time, but the correct way. This way we can rely on that and make sure that it's actually valuable rather than just garbage. And that is probably the biggest lift for a hospital because of the size and the number of people that are involved in all of this. Building database is the easy part. Getting people to use it in a valuable way.
Oh, I agree, especially if you want it on a daily basis.
Yeah.
In the next slide, again, you focus on real-time data, and I found this particular table fascinating because it's you use two most complicated procedures, basically, which makes your hospital a high-level institution, is the open heart and the heart and lung procedures. Anyone want to make a comment for us? I'm sure Dana she's the
I'm the Queen of Hearts, that's right. I'm the Queen of Hearts. So
not only this, I want to make a comment to the audience is that Dana is a nurse who became a CEO of a very complex organization at times where the concept of a teaching hospital was a dream. It was a small community hospital in rural Suffolk with very little potential. And since Dana came, everything changed, we grew. You have a beautiful residency program that I had the privilege of working with your residents, as you recall. And here it's fascinating because Dana also helped to shape the cardiac data in the North Shore, which is the beginning of this type of program. So I did want to give you this accolade.
Thank you very much. Looking at the cardiac program, what you and I worked on, Yosef, was a lot of regression analysis and data analytics. And Mary and I had this conversation before about the Department of Health reporting. When we put the open heart program here, this is relatively new. It's only about 11 years old. When I came here, I think it was the first year. When we did it in 4.5 months, we put the program, we cleaved Manhasset, brought the program here. But what this shows us is the acuity of patients, where they're coming from too. Just by looking at this precipitates a lot of other questions, right? Like where we have physicians who refer to us. And sometimes I'll see a doctor's volume or referral to us drift, and I'll ask, did we have a bad outcome? What did we do? What does that look like? And I get involved in cardiac every so often, as these guys all know. I'll walk back there, but this is a finger on the pulse of transfers, elective and in-house. What I like to watch is the elective volume. I want people to want to come here. When I first came here, there was not much elective volume. It was podiatry. But what cardiac has done is elevated all of these boats in this community. But as you said, it's a rural hospital. So we are not a hub and spoke institution at Northwell. We bring the care to the patients in this community. And, I love the fact that a cardiac program was put here. My story is we had a patient who came from Bayshore who did not want to come to Manhasset because it was, and if anybody has not been to New York, it's only east and west travel by public transportation. So they had to go to Penn Station, take another train over to Manhasset, and then take a bus or a cab. And it was about a 3.5-hour turnaround with about, I think it was $45 then. Gentleman wouldn't have his surgery because he had children and his wife couldn't afford it. So when I look at what this does is it looks at where the patients are coming from by region, and allows us to continue to, deliver that care. In addition, we have the ability to see all of the cardiac patients on all of the cath lab tables. We have ultimate quality oversight for Peconic, Huntington, and Mather, because we have a cardiac surgery team here. So if a patient's on the table at one of those hospitals having an angiogram, they call our surgeons or our interventional doctors, and they will see the images while the patient's on that table and decide if it's safe to do it there or to transport here. So we drop a helicopter and bring the patient here. So it's immediate visualization. When I first took over the service line, we had a T1 line that went under the LIE all the way to Manhasset. Now it's internet based, and we can see anything anywhere. So the connectivity is not just convenience, it's patient safety and quality outcomes. And I actually have signed with the CEOs of those respective hospitals to oversee their quality program.
Wow.
Yes.
It's really amazing. And this leads to the other real time data in terms of the flow chart. And I really like it. I love flow charts, but so anyone wants to tell us what we see here?
Sure. I love flow charts too. Year over year trends, we get to monitor volumes and see basically what's the increase in services and how do we support that, and how does then that affect other areas, and to Donna's point, what's going on, where are services going, where are they coming from, and then how that affects, what's the downstream effect, how does that affect radiology or the laboratory, and it's really a great thing. Donna mentioned it before. We're highly regulated through New York State Department of Health, and this just is one more way of us to be able to do the analysis for monitoring everything that goes through that service.
And yeah, I think when you see a blip up, I'll say to Marianne, if the volume's going up, is it, we're doing a lot more of the transcatheter valves. What are we doing? And, in open procedures, higher acuity, what are we looking at? So we really get involved when the volume's up a little bit, just to kind of see what we're missing. But this is an indicator. Go ahead, Derek.
You need, in order to make any decisions, you need the context of a flow chart or a run chart in order to see where you are and where you're going and really what's going on. Just an isolated data point, I don't have to use it so super. Isolated data point itself is really just a very, very small part of the story.
So I'll tell you something. First of all, I'm very proud to sit with you here, listening to you, talking about data. I said to myself, wow, I think the future of the executive group in any hospital, they want to survive dynamically. They will have to have people who understand this type of information, how to analyze it, and how to change processes. Because you described not only did you use the data, but you develop programs to save lives. And this is really the key to all of it. Otherwise, why we are doing it?
Right.
Because this is a huge investment. I mean, it's not simple to connect the dots with the computer. People think you push a button, it happens. But
I think that's very important. Everybody says Donna changed the hospital. I have hired the right leaders who challenge us. I'm challenged. I get challenged constantly. And you allow that. You want that. You want people to challenge you, as you know, definitely, Joseph. But looking at some of this stuff, Derek we'll look at readmissions. In the state of New York, we get hit twice by them. Their readmissions and then their cardiac surgery readmissions. So that's, Derek will push back and say, but the patient was admitted we had a patient who was killed, believe it or not, by their wife on the 29th day after discharge, and it counted as a mortality. I had to call the state of New York and say the person was killed by his wife, and the answer was, but he's dead, right? So, and I actually look at that and say, if you're able to articulate, did we miss something? Was there something that happened? And Derek has his finger on the pulse of that, but it's constantly, I call it clusters of people talking about a problem and a process. It's the right people.
so in the next slide, we really have a process in this organization of prioritization. And I love it, of course. And I would love Marianne to talk about it briefly.
I think to jump off of what you just said, we are fortunate to be a part of a larger health system. And, we have there is a tremendous amount of information across all of our hospitals. We share best practices, we share lessons learned. So it's sort of the good, the bad, and the ugly, if you will. I mean, we share everything that's great and everything that's terrible, because you don't want someone else to make the same mistake. And at the same time, you want to share if you have a best practice and have it go across. I mean, whether it's across medical boards and or PICGs, our medical directors, all of the medical directors meet, all the nurse execs meet, all the quality leads meet, our executive directors meet, and then within regions and service lines. So there's a tremendous amount of space and an invitation for sharing. I think that's what it is. I mean, the transparency across our organization is pretty strong. Everybody wants to just share, not always the best stories, but ones that we can impact the patients the most in our thing. At the core of this, though, is our PICG and our performance improvement, and how we at our local level here can affect change. We have given our leaders, our members of PICG, a crash course on science improvement, PDSA. We give them a template to help them. We show them how to use the EMR to identify opportunities. think we've had plenty of projects. I don't know if you want to share a project or two. Derek chairs our PICG, but I think it's just a way that then and I'll give it to you, but then our PICG shares up to medical board, up to the board of trustees, and then it expands out to the rest of the health system. So I think we're very fortunate.
And this is, if there's, knowing our journey here at South Shore from the community hospital to the tertiary hospital, I mean, this would be my recommendation for anybody who's looking for a way to up their quality and to improve the quality of their hospital, to start with the PICG. We had a captive audience, a captive group, and they were doing good work. They were doing good work, but it wasn't based on data. It wasn't based on science. It was really based on what we think is going to work well, what we think is going to work. We gave them just a little bit of improvement science. We gave them the templates to request the data. Now they're requesting data for their projects. We're able to give it to them. A lot of projects come out of our PICG, very small tests of change. Mobility is a big one. There's a lot of projects going on about mobility and how it's related to patient stays and outcomes. There's plenty about patient satisfaction and certain things that we do that will improve or adversely affect patient satisfaction. There's plenty about following the guidelines that we, as an institution, but also as the standards are set, how we follow the guidelines and what the barriers to following those guidelines. These are the types of projects that each one of our groups are using, and they're incredible.
So, Dana, it looks like this type of diagram touches all your pieces of the organization.
Having been in the service line for cardiac, I look at it as a horizontal world. This is a vertical world, but PICG and, establishing ownership and accountability for each department has spawned from PICG. If we're here to take care of human beings in a bed, we better do it right. And that's what, this has small tests of change have made huge impacts. Bringing in the right physician leadership has made huge impacts. But what's really important too is we have some analytical people that we put in each department, so they now have data and IT data. We have BI, we have business intelligence, we have every possible thing, but it always boils down to what's the impact of the human being in the bed. So it's just so important to share what you know, and I think this is the best way.
Great. So as we proceed, we are moving now to artificial intelligence.
And before that,
Oh, I'm sorry. You're right. The benefits of the electronic medical record. So again, Derek, if you want to make a comment on that, please.
yeah, of course, it builds upon the conversation we had about the clipboard and the teletracking expo that we had. Having everything all in one place allows us to sort of allows us to be able to recall it. It allows us to be able to analyze it, and it allows us to be able to look forward. Collecting it and putting it into a note where a doc that can actually be read versus the old paper charts where we had to decipher it is probably the biggest one. But having some decision support attached to it was one of the bigger sells for EMRs in the beginning. Things like allergy checking, things like dose checking on the medication side, and that's when EMR first became usable, was on the prescription and the order writing side. But now it encompasses every aspect of patient care here. And we added along the decision supports checklists. We've got guidelines. We've got standard ways of treating patients. We want to present providers with these checklists to make sure that they have all the elements that they need to fill those checklists, but also follow those guidelines. Put it all together, pull data out of it, and then we can figure out how well we're doing. We've got all these data entry points. We take that data back out, we analyze it, and we're able to see where our opportunities are and where we're doing well.
But I'm really fascinated that underneath the 3 columns you put as a base artificial intelligence. So do you want to make a comment on that?
So this is relatively new in healthcare. I mean, extremely new. So much so that I only know about 4 people that really do it and do it very well. We have data scientists here at Northwell. Dr. Jamie Hirsch is one of them that actually run a program to do this for us. Artificial intelligence itself is a pretty generalized term, but we're starting to use very little subsets of AI to make associations that we can't make on our own by analyzing data, but also to make some suggestions and to make some of the tasks a little less manual for us, or to automate some of them. We're still in an infancy.
So if you put certain variables,
Yes.
certain words in the sequence, in our sequence as human beings, the computer can correct it.
Yes.
Now we have to figure out how to control it.
Yes. Control it.
It's like,
For sure.
Yes. Well, control it, and we can go to the next slide.
Yes.
Not only control it, but also to validate it is probably the bigger question. How we usually do things in medicine. We've got a tool. We've got to validate it, make sure that it's working the way that we expect it to. Like I had said, artificial intelligence is pretty broad. Really, what we specialize in healthcare and here at Northwell is more on the machine learning part. Natural language processing and speech to text is fun to have, but the real value for AI is on machine learning, at least right now. What machine learning does is it takes a very large data sets of related data, and it will analyze it using a bunch of algorithms that have been designed to find associations that are not apparent. It'll analyze it and train on that data set, and then come up with a bunch of attributes that may or may not be weighted to contribute to an outcome that we're looking for. For example, we use it here in Norfolk. One of the very first things we used machine learning and AI for was to determine patients that were in a bed that were ready for discharge. Dr. Hirsch put together a database of all these patients that were going to be discharged within a certain amount of time. He recognized the characteristics of those patients. And now we get a report of all the patients that meet those characteristics. They may be ready for discharge despite us not really putting in the discharge order yet.
but you make the final decision
And
as a human being.
As a human being,
So-
we're still at the part where it presents us with some options, and we have to make the decisions. Yes,
So you control the data and you analyze it
Yes.
to make sure that it makes sense.
exactly.
And with artificial intelligence, eventually we don't have this step.
Yes.
I hope not, but this is what it looks like.
Right.
I'm really, to be honest, I'm very scared
It's scary.
because I don't think if you have a woman who went through a C-section, there'll be one algorithm, and it may be similar to somebody who had an open heart surgery. I don't know what the AI is going to do. But as a human being, you can distinguish between the population. I don't know if artificial intelligence can be so sensitive to distinguish.
I agree. And we commonly speak about the art of medicine, and I think that's really where that lives. There's a lot of data that needs to be input in order for AI to work correctly. And a lot of the data that we get input from our senses, we don't necessarily even realize we're doing it half the time. How a patient walks into the room, how they interact with other people. That can't really be put into a database, and that comes with experience and the art of medicine. Eventually, I guess if the data collection systems become sophisticated enough, we may get a step closer to full automation, but I don't think we're going to be there anytime soon.
Right, but we don't have a choice. We have to continue to work in this direction because this is what is happening in the field. This is really great. Do you have any comment you want to make? So the next, which is what's fascinated me, care plans, because it's so complicated. And again, when I worked with Dana, we did everything by hand. And of course, we reviewed it and we looked at the information in terms of morbidity and to classify the patient. But now we have a computer. Tell me about it.
Yeah. So I think what the care plan does, right, is take all of the science and all of the evidence-based information and puts it all together because, and it's going to decrease as much variability in the care of the patient as you can, right? So we talked about this earlier. If you have a nurse who's been here for 3 years, or you have a nurse who's been here for 30 years, if you have, in this example, a patient who's had a hip replacement, we're going to do these same 4 or 5 things for that patient every time because it's been proven to provide the best and the greatest outcomes. So it just reduces the variability and it puts it in. And the computer, the EMR, allows it to happen. So there is no paper, let's do research, let's figure out, it's all right here. And it's at the fingertips of anybody who wants to pull it up.
And you can retrieve the information to make
Absolutely.
decisions or study PI.
Yes, in fact, the group that we get these care plans from frequently does that. They will look at the data and they'll look at the outcomes and they get updated from time to time because of based on the data that they pull from them.
This is great. So after putting so much work, so many databases, and, education, and so on, you did quite well with the leapfrog.
We sure did. We got our A.
You got an A. And where did you move from?
Initially a D,
A D. How long it took you?
3 years.
3 years.
Mhm.
3 years is very short, by the way.
A lot of work.
Well, we had to change mortality by a fraction of a
Yeah.
percentage to years.
Mhm.
It's very complicated. So anyone wants to make a comment on that? This slide, beautiful slide. It's an amazing outcome.
Well, barcode administration, you need the electronic medical record in order, for compliance. And I think having the ease of pushing the electronic button to say, here's our barcode medication administration, you can see where the compliance is and, where we need to do education. And they actually, if you go to the next slide, real quick, Derek, you'll see, year over year trend. It took us 3 years and we improved, almost 6 percentage points, just being able to look at the compliance and do education. In the old, that you wouldn't have done this without an electronic medical record, first of all, but then, being able to, push the button and use this analysis in order to make the improvements. Medication reconciliation is the same way. That would have taken hours and hours and hours of work to analyze. And now it's really pushing a button and looking at the fields that are filled in and completed.
What I really like about this table is that the clinician can understand. Because you present a bar graph to compare, and then you write a linear flow.
Yeah.
To show the direction.
Yeah.
So this is very important because this is what clinicians want. They want facts. They don't want you to tell them what is a regression or some deviation.
Where do I see and how do I fix it?
Is it going in the right direction or isn't it?
Do you have any other last comments to make? So we are going to sum this meeting conference that we had, and we are going to wait now for a question and answer session. Thank you very much.
Thank you.
Thank you.
Joseph, do you want to put the camera on in case we have any questions?
Yeah.
Hi there. Corinne, do we have any?
Hello
We
again,
don't
and,
have any questions.
Who made a comment? I didn't get it.
There was no question.
No question asked? Okay, so we're going to summarize it. I hope you had a good session today. It took us a long time to put it together. You can see it's a combined work of many individuals. And I would like to thank the Southside Shore North University Hospital for their hard work. So if you want to make a last comment.
Thank you. I want to just thank you for the opportunity to do this talk, this little presentation, though, as we were speaking about before, was really, it was really enjoyable. The conversation itself was a very enjoyable conversation, but also putting it all in perspective. I hope we did a good job of showing our journey here at South Shore, going from a community hospital to a reliable, our journey to becoming a reliable tertiary institution, and how data and the EMR played a big part of that. We touched on AI, and in the closing remark about AI, my career in medicine has been lucky enough perhaps to straddle both the medicine that was on paper to the medicine that was on the EMR. And I think we're undergoing or on the verge of a similar type of transformation where we're going from the EMR to using AI in the EMR. And I'm very excited to see where that goes.
Great, wonderful. Marianne, would you like to make a comment?
Sure, I would. Thank you. I think like Derek, this was a great opportunity for us to look back and see what our transition looked like, and how we went from that small community having a little bit of data and not really sure what to do with it to having so much, where do we use it and how does it get better? One of the things we didn't touch on in the presentation was our magnet journey and how you have to have so much data even before you apply, and how the electronic medical record has helped us with that, because you have to show improved outcomes, and you have to be able to consistently work on performance improvement projects. And how do you do that? With the electronic record, we can get data at a unit level, not just the department, but a unit. So not just medicine, but to North. And then how do we fix that? And how do we make it better? You don't want to fix something that's not broken. So you need to see where you're doing well. And I think being able to then benchmark that data against local, state, federal, even within our own system is huge for us. So it's just another part of our, of our growing pains and otherwise here. But thank you for the opportunity. We hope that you were able to gain some insight from our experience with this.
Thank you very much. Okay, with this, Andrea, we are concluding the session.
Thank you, South Shore University Hospital. Congratulations on your journey. And thank you, Corinne, for taping the session for the American College and displaying it.
Thank you.